join ചെയ്യാൻ പറ്റിയോ? തുടങ്ങിയിട്ടില്ല, ബട്ട് എൻ്റർ ചെയ്യാൻ പറ്റിയോ? ഓക്കെ, ശരി ശരി, ഓക്കെ ഓക്കെ ഓക്കെ, ശരി ശരി. English, can we start now? Can we start?
Yes, sir.
Yeah, we'll start now. People are joining, no? Okay. So good morning, everyone. Yeah, as usual, we start with a short case. I will start by share screening. Is my screen visible?
Yes, sir.
Yeah, okay. So it's a short case. The story of a 45-year-old lady is a progressive difficulty in walking and stiffness for the last 4 years. No sensory or bladder complaints. And she also gave the history of difficulty looking up and bending for the same, looking up and bending the neck for the same duration. This is the video, short video of the patient.
Backward backward okay, ಒಂದು ಕುನಿಯ ನೋಕಟ್ಟೆ ಮೊಟ್ಟೋಡ ಕುನಿಯ ನೋಕಟ್ಟೆ ಕುನಿ ನೋಡ್ತೆ ಇನ್ನೇ ನೋಡ್ತೆಮ್ಮ ബാക്കിലോട്ട് ആക്കിക്കേ ബാക്കിലോട്ട് നോക്കിക്കേ ശരി ഇനി അമ്മ നടന്നമ്മ ശരി പൊക്കോളൂ
Tremendous stiffness of both legs. Both are
ശരി അമ്മ മതി മതി.
So the findings I'll tell you on examination. This can bend little bit, but extension is totally defective. So in examination, there is restriction of extension of the neck and bending the trunk. Painless are normal. Motor system, tone upper limb, tone power normal in the upper limb except mild spasticity. But severe spasticity of both the lower limbs, but power was normal. DTR, both upper and lower limbs are brisk. Pandas indefinite, sensory normal. So what do you think is that, what do you think is the likely diagnosis, the site of lesion and possible diagnosis? Anyone? Am I audible to you?
Yes, sir, you're audible.
Yeah. Then anyone
Sir,
can? Yeah.
this looks like she has a myelopathy, cervical myelopathy,
Okay.
and since she has a gross restriction of neck movements, I would consider something like ankylosing spondylitis or something.
Okay.
Spinal
She's also got,
stenosis.
very good possibility because she's also got problem in bending the trunk. Okay, this is a very short case. So what do you want for the patient? What investigation you need? She came with a CT scan of the brain. This is a CT of the brain, which shows hypodensity in the putamen region and the antemental capsule, and bilateral hypointensity in the corona radiata. These are the same cut only. So what do you think about now?
Cadastral, sir, is it possible?
No. Anyway, this is, I'll tell you. So are we satisfied? We are not satisfied because
No.
the findings are not explained because you got progressive spasticity upper lower limb, lower limb. Moreover, she has got a restriction of the neck and restriction of the trunk. So as you said correctly, more likely some problem in the spine should be there. So we need imaging of the spine. Now this is X-ray spine, cervical spine. Anything abnormal in the X-ray cervical spine? I'll show a zoom up view. This is a zoom up view.
There is ankylosis is there, sir.
Pardon? Yes.
Ankylosis is there, sir. Means entire there is a calcification in the entire longitudinal ligament.
Very good, very good. There is a you can see the calcification in the posterior longitudinal ligament. Thick calcification, as you said, is correct. Right. So this is the MRI of the patient. Usually extensive calcification of the posterior longitudinal ligament here. Sometimes it present also posterior ligament of fiber also thickened at certain places. This is cervical spine. At multiple level, you can see the prominent calcification extending down up to the thoracic region. This is a T1 weighted sequence. This axial cut showing the calcification, compressing the cord, producing the hypointensity in the myelomimetic changes. And this is the thoracic spine, again showing calcification and some ligamental fiber calcification as well posteriorly, but mainly in the anterior part here. Extensive calcification of the posterior longitudinal ligament. So the diagnosis is what? OPLL, ossification of the posterior longitudinal ligament. So they can have myelopathy with myelopathy of long duration. Always consider this possibility in a non-compressive, so-called non-compressive myelopathy. Any questions in this patient?
So what are the brain lesions here?
Pardon? Wait one second.
Sir,
why were the upper limbs not involved?
Upper limbs were affected, in fact. Yeah, there is spastic, but not weakness was not there. The reflex were brisk.
Okay, sir.
It predominantly in the lower limb. The compression was, even though ossification was there seen from the cervical region, the maximum compression was actually in the thoracic cord, which you can see here, this area.
Yes, sir.
Cord is compromised at that area. In the upper part, calcification is there, but Core compromise is not that much.
Yes, sir. Thank you, sir.
So could it be fluorosis?
It could be fluorosis, but the fluorosis, I don't know, it's extending along the posterior nodular ligament alone. It's, I don't know, it can, I'm not, I mean, we don't see fluorosis in Kerala. People coming that side, Andhra and all, they'll be able to say better whether this can occur like that. But
The
this,
significance of CT changes, sir, in this patient? Any significance, sir?
I don't know. Frankly, I don't know why this CT changes has occurred. Absolutely, I don't know. You know,
So
the
there
point
are,
is, yeah, tell me, Umar.
there are calcification in the anterior longitudinal leg ligaments also.
Yeah.
So, and the spine appears slightly distorted, something like a loss of lordosis and something like that.
Right. The OPLA need not necessarily be confined to the posterior nodular ligament. Can also get other ligaments also get calcified. Like for example, ligament of flava and that also can get calcified.
So fluorosis in the bone also will be involved.
Yeah, that's the thing. Fluorosis bone and also. Yeah, I not much idea about fluorosis, so that may be there. And classically, what I learned when I was in Chandigarh is that they got calcification of this endogenous ligament in the forearm. That's forearm, we take extra forearm, look for the calcification of the endogenous membrane. Okay, shall we go to the next case?
Sir, what could be the cause for the brain lesions?
No idea. The other doctor was also asking me about that. I have no idea what it is.
That may be an impact.
It doesn't look like it, in fact, because there's symmetrical bilateral hypointensity and under some kind of a occult leukodystrophy as specimen there. You know, many of the leukodystrophy-like changes can remain asymptomatic for now. Leukodystrophic-like changes, they may not be symptomatic.
One doubt.
Yeah, please.
Sir, what treatment can we give? She has extensive calcification.
Yeah, in fact, I did not do anything because I only put her on antispastic treatment because the weakness was not there. Because if you do surgery in this patient, whatever surgery, 2-3 surgery which I have done had result in heaven, they all worsened. Because extensive calcification, they make, when you remove it, when you do the surgical intervention, that will compromise the circulation and then go into problems. So I do not advise surgery in these patients. This is out of my experience. Surgeon will take up a surgery, but the results are not at all good.
Yes.
Now, we'll go to the next case. It's a good case. This is from Dr. Dilip Mathan, courtesy to him. It's a 48-year-old diabetic lady. The case was seen by me 2 months back with progressive difficulty in walking in the form of loosening chapels and imbalance while walking for the last 8 years. History of difficulty in getting up from the chair and slumping to the ground for the last 1 year. There is an history of weakness of both hands for the last 6 months. So total 8 years history of difficulty in walking, then followed by slumping to the chair and then weakness of both hands for 6 months. No sensory complaints, no pain anywhere, no headache, no neck pain. This is the video of the patient. Ocular movements are all normal, tailors are all normal. Neck muscles normal. Tone normal in the upper limb. Not much weight. Total elevation was normal, but convection was weak. Deltoids were weak bilaterally. Biceps, both biceps were weak. Not very weak, but 4 to 4 plus power. But triceps were normal. External rotators were weak.
ഇങ്ങനെ ഇരിക്കണം, ഞാൻ ഇങ്ങോട്ടാക്കി സമ്മതിക്കും. ഇനി അകത്തോട്ട്
The internal rotators are all normal, very normal.
അത്
Good power.
അത് കറക്റ്റായിട്ട് പിടിച്ചു.
Three sections are normal,
ഇത് നോക്കാം, ഞാനത് കാണിക്കാം, ധൃതിയില്ല, സമയം ഇഷ്ടം
but finger extensions were weak.
പൊക്കി പിടിക്കും, പൊങ്ങി നിൽക്കണം. ഇത് പോകട്ടെ,
Finger flexors normal.
ഇത് മടക്കി പിടിക്കും, മടക്കി പിടിച്ചുകൊണ്ടിരിക്കണം, മടക്കി പിടിക്കണം. അത് ശരി വിട്ടെ,
Small muscles are all weak in this patient.
ഇങ്ങനെ ഇരിക്കണം,
Four.
ഇത് പൊക്കി പിടിച്ച്. അതായത് ഇങ്ങനെ പൊങ്ങിയിരിക്കട്ടെ, ഇത് പിടിച്ച്. ഇനി കണ്ടിങ്ങനെ അകത്തി
Crochet were weak.
അടുപ്പിക്കാൻ സമ്മതിക്കരുത്, അകത്തി പിടിച്ചോ.
There's no finger nose incoordination.
ഒറ്റയ്ക്ക്
Let's see, abduct the arm, that's a good point.
ഈ കാല് പൊക്കിക്കാം.
The lower limb, the weakness of hip flexion.
പിടിച്ച് നിർത്തണം, പറ്റുമോ നോക്ക്. പിടിച്ചോ, വിട്ടോ, ഇത് വിട്ടോ നോക്കിക്കോ.
The extensions were weak bilaterally, about
പിന്നെ ചവിട്ടി മാറ്റണം, എൻ്റെ കയ്യിലോട്ട് ചവിട്ട് പറ്റണില്ല, മൂർക്കണം, ഇല്ല, ചവിട്ടി മാറ്റണ്ടേ.
they can easily break the cortices pulse when strong. That is little more powerful than on the right side. Flexors are also weak. Abductors are weak. Adductors were good power. Knee flexion was weak. Dorsiflexion weak, plantar flexion little more powerful than dorsiflexion. Questionable weakness of plantar flexion. It's also weak. EHL weak, FPL weak. The reflexes right upper limb normal. Left upper limb biceps supinate normal. The triceps was just elicited. FPL diminished, but just elicited. But right triceps was well elicited. Both knee and ankle jacks were absent. Pandas indefinite. Sensations all normal in the upper limb. Vibration was impaired only over the toes. Upper limb normal. He said yes, sir. Except over the toes. JP is normal in the upper limb. There she made occasional mistake. Okay, this is the gait of the patient. He could not stand without 2% support. And the way she walks, we're battling or looking. Quite 2% to walk. So summarizing, cranial is normal, motor system upper limb stone normal, power weakness of both deltoid, external rotators and biceps, normal internal rotators and triceps. Finger extension says all small muscles for the hand were weak, but wrist extension was normal, finger flexion was normal. Come to the lower limbs, tone normal, power, weakness of both hip flexors, knee extensors, knee flexors, weakness of both dorsiflexors, hip extensors, hip abductors, questionable weakness of hip adductors and plantar flexors. Plantar flexor appears weak. DTR upper limbs or left triceps is absent or diminished. Rest of the DTR normal. The lower limb, knee and ankle joints are absent. Plantar indefinite. Sensations normal in the upper limb, impaired vibration, JPS over the toes because it's a diabetic concept. Gait bilateral badly, could walk only with 2% support. So, what do you think the patient is likely to be having? There is a site of lesion. What is the possible diagnosis? If you want to clarify any findings, you ask me, I will show the video once again.
Sir, there is a history-wise, there is a progressive weakness from the last 8 years, sir.
Yes.
First started in the distal muscles, then proximal lower limb muscles, then the distal upper limb muscles. Examination-wise, he has a L-Element syndrome. Both proximal and distal muscles are involved, and reflex are absent in the lower limb and just gelcephalus in the upper limb.
Okay.
Sir, history-wise, it is neuropathy. Since onset is from last 8 years, sir. It since it is length dependent, like history-wise also, some metabolic or hereditary neuropathies are possible.
Okay.
Second possibility of myopathy are to be ruled out, sir.
You're right, because only thing is that, as you said correctly, the JPS sensory loss can be due to diabetes. Okay. Neuropathy is a possibility. The only thing is that the proximals are also significantly affected. In the lower, see the way she walks, severe
Yes,
back, the plantar was relatively well preserved. Something like still symmetrical peripheral neuropathy is just like. And moreover, in the upper limbs, you look, he has got severe weakness, the external rotators, biceps, some muscles are spared. On the other hand, biceps is spared. So that pattern is slightly odd for a peripheral neuropathy. But I agree with you, it could be distal, history-wise distal to start with.
The patient has predominant
Pardon?
patient has predominant motor weakness.
Yes.
Differential muscle involvement.
Yeah.
So the first possibility is a muscle disease.
Okay. Right.
So it could be muscular dystrophy. Second, due to finger flexion weakness and on inclusion body myositis, myopathy can be considered in this patient.
Inclusion body myositis is a possibility, which affect mainly in one peculiarity of inclusion body myositis is that in the upper limb, the finger flexors are affected maximum. The flexor digitorum long is affected maximum compared to the other muscles. Here, that muscle is spared. And the lower limb quadriceps is maximally should be affected. Here, quadriceps is affected definitely, but hip joint muscle are also affected to a great extent. That possibility that not ruled out. Not much of a wasting, but that's also the distal loss could have been due to that diabetic neuropathy itself. Yeah, it's a good possibility. Except the distribution of weakness is not classical, but duration can go with that.
Sir, in view of the proximal and distal involvement, if the absent reflexes more like a radicular neuropathy, and a CADP variant, like which is the low, like monoclonal gammopathies, which is very, very slow.
Yeah, correct.
Can be a possibility.
Yeah, that's also a possibility. Radical neuropathy to CADP or CDP variant like MADSM variety, etc. can present like that. Okay, so these are the possibilities, good possibilities, all of it.
Sir, the waddling is mainly such a muscle disease, something like myopathy. And the reflexes, because it's been there for some time, and the weakness, I mean, the determinant reflex could be part of the myopathy itself.
Yes, exactly. You said myopathy. It's probably the distribution was not favoring a particular pattern. That's the only problem. but that possibility has to be considered again. Okay, so what investigation you want now?
Nerve conduction, sir.
CPK.
CPK.
CPK is normal.
Nerve conduction.
CPK need not be normal in the case of inclusion body myositis. CPK will be normal. They don't be very high at all. In many muscular dystrophy, CPK can be normal. So nerve conduction will do the nerve conduction. This is the nerve conduction. Upper limb, median, ulnar, peroneal, tibial, amplitude all normal amplitude. Distal latency is normal. And conduction velocity is normal. Okay. Then the FA studies, FA latency is also normal. Sensory potential is all normal. Except the sural on the left side, it is decreased. Probably some technical fault. The other side is present. Essentially, conduction is normal. So, what do you think now?
Peripheral neuropathy is unlikely, sir. Needle EMG can help, sir.
Okay, needle EMG can help. Okay, let us see what differentiate myopathies. Also, series of investigations done from in the previous hospital. I just go through the investigations. ANA profile they did negative. CSF IgG was normal. HbS aged, serum copper, ferritin, vitamin B12 normal. ACA levels normal. Pyruvic acid 0.22. CSF was done. 2 cells, protein 60, lymphocytes, only 2 cells, sugar normal. EMG was reported, I did not do the EMG. EMG was reported to diffusely, relatively symmetric chronic neurogenic process. I don't know what they meant by that. Conduction was normal, particularly. Most consistent with a polyradiculopathy, but one cannot make a diagnosis by finding neurogenic process. Polyradiculopathy can be anywhere from anti-convulsant down. In inflammatory myopathy also can produce EMG findings as of a neurogenic pattern. So this alone one cannot conclude, but this is the report they have given. So the VEP BHP was also normal. MRI brain was done, which showed a small meningioma around the right parietal convexity. MRI spine shows degenerative change, cervical, forget about that, all things. And ligamentum flavum thickening in D1 to D10, etc. So what else you need?
Muscle biopsy.
You want muscle biopsy? Okay. Anti-GM1, this ganglioside antibodies were done. They are also negative. What do you want to do?
So what about the thyroid function test?
Thyroid function, I did not do that. It doesn't look like a thyroid. Do you think so?
The protein electrophoresis.
Protein electrophoresis, I don't know. They have done extensively, so I did not do that. IgG, CSF, no ANA profile. Okay, but what you had in mind? You thought maybe a CDEP like thing, no? But the NCV was normal.
Monoclonal gammopathy cells. In the upper limb, NCV normal is against that diagnosis. But in the lower limb,
lower limb also normal. Okay, so
to have a CIDP or neuropathy with a normal SNAP as well as the normal motor condition is very unlikely. And the way she walks with the gross waddling would tell you that it's something more of a myopathic process that's going.
One I think I like about you all is that you're all trying to analyze and coming to the point. That's most important in a neurological case. Anyway, let us see what this case. Before I go to this, I'll just run through that and see the patient after 2 months. The treatment. I put some treatment which I'll tell you later. How has improved? Just 2 months story. It was normal even before. The abductus was good power. It's recovered almost normal. It was weak previously. It's overly. Infection remarkably improved, and she could good power. Those was also improved than before, but not totally. The point I want to try is that she could even enter from lying down position. To get from the bed. What happened? I don't know what happened that particular thing. From here. Yeah. The effects also. She could even get sit diagonal position. She was not able to do earlier. The reflexes, the left triceps, which is almost absent, has come back. It has actually become brisk now. Knee jack and ankle jack continued to remain absent.
Calcium phosphorus are normal, sir.
Pardon?
Calcium phosphorus.
No,
Calcium.
Just finish the video. The joint cells which is absent earlier has become normal now. It is able to feel the vibration and able to set the joint cells at correctly. The Bindu, whatever you're telling, I did not hear.
The calcium phosphorus, calcium levels.
They're normal. They're all normal. So, what do you think the patient might have had now? And what
vitamin D deficiency, sir?
No, I'll tell you what the story. But go back to the story again. Now, see this. Now, what does NCA suggest? Let me go first question. You all know it's an element syndrome. Everyone says element syndrome, correct? Predominantly motor, no definite sensory. So it can be anywhere from the anticonceptual downward to the neuromuscular junction. But being the reflex absent means unlikely neuromuscular junction. The possibilities remain okay. Now, what does NCA suggest? That's my question. NCA says conduction block. Why did I say conduction block? Because he has got significant weakness of the muscles and the CMAP amplitude normal. And even after 8 years, no significant wasting of the muscles. You got the point. So remember Kumara, this I have told many times, Kumara squared. Whenever somebody has got weakness of the hand, element weakness, not what historical, but a good CMAP amplitude, that's conduction. See, otherwise, the CMAP should go down, whether it is to anterior constant, whether to axonopathy, whether to the muscle weakness. Muscle weakness later, but that can produce that. So otherwise, always consider the possibility of a conduction block proximity. The other point favoring demyelinating disease is that she has got no wasting even after many years. 8 years story, muscles are not still good. Unlike hereditary neuropathy, you find with the might get hammer toes and things like that, that's not there in this patient. So weakness with normal CMAP amplitude is in proximal contraction block. Then you may ask why F5 latency is normal. This point also I told last time. See, we are not measuring the chrono dispersion in the FA. We are only measuring the minimal latency. Even if out of 10 fibers in the root, if 2 fibers are left behind, FA latency is normal. The other fibers are conducting normal. So FA latency cannot be laid upon to diagnose as ADP or CADP unless all the nerve fibers in the roots are affected. So that shows the what treatment was given. She was put on of 1 gram BD along with Viceron 60 milligram OD, even though she was diabetic. And has come for follow-up of this set of the video was after 2 months after follow-up. So always keep treatable conditions like CADP as Bindu was suggesting. But only thing is, I know why you are all misled with the conduction findings. This is the point you have to keep in mind all the time. See how many times you have seen GBS with the normal conduction. Have you seen normal conduction from the GBS? What conduction is normal? But they improve everything with IVG and things like that. Okay, any questions?
So it becomes only a clinical diagnosis, purely clinical diagnosis.
It's a clinical diagnosis.
No investigation support.
Yeah, the investigations are supportive, but the only thing is the correct interpretation of the investigation in the presence of the clinical finding. That's important. So always never go with investigation, go clinically and find out what are the pitfalls in interpreting the investigation.
CSF protein was 60, that is slightly high.
Yeah, that's the point. That's another point.
One doubt.
Yeah, please, Bindu. Bindu, tell me, Bindu. Yeah. Somebody asked me a doubt, please.
Sir, suppose if we do an MRI contrast of the radicals, can it pick up enhancement?
May or may not pick up. Sometimes they may pick up, sometimes may not pick up. But that's one way of finding there's a lesion is there in the roots also, correct?
So can we say this is MMN?
No, it's not MMN because his patient got sensitive findings were there, which is improved. She had JPS sensory impairment and vibration loss, which if it were not improved, I would have thought it could have been due to the diabetes. Maybe in that case, we can consider the possibility of an MMN. But she had sensory also. And the findings are all as almost symmetrical weakness, not like a multifocal type of pattern. If you take upper limb, lower limb, they are myelopathy almost symmetrical. Not much of difference between side to side. In MMN, only that multiple patch in a multiple nerve-like pattern. So it's a variant to see it.
What would be the finding in the paraspinal EMG in this case? Paraspinal EMG.
EMG may be used in the case only in demyelinating disease. The only abnormal spontaneous activity will not be there, but you will have decreased recruitment will be there. Denervation will not be there, recruitment will be decreased. That is evidence of it. That means some of the muscle fibers are not conducting up. So decreased will be decreased.
Sir, in hereditary neuropathy, sir, if it is demyelinating type also, we see many times lot of atrophy.
Lot of atrophy, correct.
Yes, sir. But in this patient, we haven't seen after 8 years of onset also, sir.
Exactly.
On an average, we see after 10 years of progression, it is more of, we think, genetic than acquired. It is almost 8 years now.
Right.
Still,
Exactly.
yes.
Yeah, correct. Your points are well taken, but this not the point is not fitting with the classical CMD like presentation because proximal is significantly affected.
Yes.
That's thing is again is hereditary neuropathy, but the conduction was not at all suggestive of hereditary neuropathy.
Yes, sir. Yes.
Usually you will find conduction abnormality because they are distally affected first.
Yes.
Like a CADP where the proximal conduction only makes the affected one.
Yes, sir. Okay, sir. Thank you, sir.
Shall we go to the next?
Yes, sir.
Okay. This is again an interesting case story of a 32-year-old female. Again, referred to me by Dr. Anu Gangadhare from Ernakulam. She has defective vision of right eye for the last 5 months, followed by the left eye last 4 months. This is a story given by the bystander. Okay. Jerky movements of the limbs often stimulus precipitated. And walking difficulty. Anyone? Walking difficulty in the form of unsteadiness in walking for the last 6 weeks, which progressed to a bedridden state for the last 2 weeks. Relatively rapid progression, subacute presentation. Impairment of memory for the last 2 months. So I'll tell the history once again. Start as defective vision of the right eye for the last 6 months, followed by 1 month later by the left eye. Jerky movements of the limbs often stimulus precipitated. Walking difficulty in the form of unsteadiness in walking, 6 weeks, which progressed to bedridden state in 2 weeks' time. Then within 1 month, she became bedridden. Impairment of recent memory for the last 2 months. So look at the video of the patient. Don't look at talking, I just talk to the patient. If the myoclonus which is having. Stimulus specifically. That comes like. Spontaneously also open stimulus specifically. That's all. Okay. Rest of the examination, she could count fingers, but she could not read letters. Pupils were normal. Fundus I couldn't see. I tried to look, I couldn't see. And she could tell the name of the relatives, but she could not tell what she had eaten in the morning. Okay.
അങ്ങോട്ട് നോക്കി, ഇടത്തോട്ട് നോക്ക്, ഇവിടെ നോക്കിക്കേ, വലത്തോട്ട് നോക്ക്, ഈ വശത്തോട്ട് നോക്ക്, ഇനി ഇങ്ങോട്ട് നോക്ക്, താഴെ ഇനി താഴെ നോക്കാം, ഇനി മുകളിലോട്ട് നോക്കിക്കേ, ഇനി മുകളിലോട്ട് നോക്ക്, ഇനി പൊങ്ങിക്ക് കിട്ടും. കഞ്ഞി കാണിച്ചേ, ജിനി നാക്കൊന്ന് നീട്ടിക്കേ, ജിനി നാക്കൊന്ന് നീട്ടിക്കേ, നാക്ക് അങ്ങോട്ടും തള്ളിക്കേ. സ്പീഡ് മാക്രോണസ് ആയിട്ട് കഴിഞ്ഞു പൊക്കി പിടിച്ചേ, മോളെ നിന്ന് പൊക്കി പിടിച്ചോ. ഇങ്ങനെ പിടിച്ച് നിർത്തിക്കേ. പൊക്കാൻ നോക്കിക്കേ, പൊക്കി പിടിച്ചേ, പാദം പൊക്കി. എത്ര ദിവസം ഉണ്ട്?
These are all brisk, the upper and lower limb. Pandara is flexor. She's able to feel the vibration up and over. So on examination, she was conscious, impaired recent memory, pupil normal reacting to light, finger counting normal in both eyes, stimulus-induced and spontaneous myoclonus, rigidity of both upper and lower limbs, right more than the left, weakness of both upper and lower, again more on the weakness more on the left side. This is the finding from others. Say when they initially examined, they thought patient had left hemianopia initially. So what do you think is the likely diagnosis?
SSP.
Okay, but she's 38-year-old.
So it can happen.
Immune-mediated encephalitis.
Hayden's variant of CJD, sir.
Okay, CJD. Then we have variant. Then anything? Windu was telling something.
It's the immune-mediated encephalitis.
Okay.
Brains.
Effect,
Limbic, something like limbic.
Okay. Right. So let's see. These are the subacute encephalitis periviral or tumor encephalitis. So this is the MRI of the patient. Impedency in the both occipital region, subcortical white matter, more on the left right side. Is it even weighted? Contrast, there's no contrast enhancement in this lesion. Okay, what does you want now?
Diffusion restriction.
There's no diffusion restriction. The diffusion film, this is diffusion film. So what do you think now?
EG, sir. EG.
EG. Okay, EG picked up. So the EG is because of the myoclonic jerks, no? Or I think muscle artifacts coming. This and the echo.
Short interval period.
Pardon?
Short interval periodic complex.
But this will look like a fast activity, no? Okay.
This is something like a SSP, sir.
SSP?
Yes, sir.
This is the complex in SSP. SSP produces not spike activities like that. They produce a large you see the muscle activity.
And the interval will be more than 4 seconds.
Yeah.
4 to 6 seconds.
Right. Minimum 4 seconds. But as the disease advances, the interval becomes shorter and shorter. Okay, what do you think now?
Sir, is it part of progressive myoclonic epilepsy spectrum disorder?
So that will not be so rapidly progressive like this.
Yes. Yes.
But we all go for again clinical. So the only I wanted to, as Butch has already told, this is myoclon. Look at the myoclon. No myoclon. That's the myoclon. Don't find in any other program. The slowness. That too. It's a slow myoclon. In fact, it has got two myoclonus and SSP. One rapid, and then followed by slow lag. Did you see that? It comes up, then relaxes very slowly. And have a look at the myoclonus 1 second. See how it relaxes?
Yes, sir. Yes, sir.
That is the once you see this myoclonus, I think I don't think any other condition can put this kind of in myoclonus, except what in facial brachial dystonic seizure. That's also slow myoclonus in my blood, because that's also very like a slow movement, like not a typical myoclonus in patient brachial dystonia myoclonus. It's also slow. So let us see now, go back to the picture. And this MR is also classical of SSP. This is the one common presentation of SSP is that occipital lobe hyperintensity. Now let us go to the EEG. So whenever you get fast activity mark because of the myoclonic check masking your EEG, what do you do now? You check the, we don't know whether underlying slow activity is present or not in this way. So you have to make this, and this is the autoimmune work first done for Bindu. Bindu, that is normal. NMDA negative. Then LG1 Casper negative. CSF showed normal CSF. Charting. Let us see the EEG once again. Change the sweep speed. I'll show the complex. That's a slow complex. See this one. I'll come back to once again. See this complex. This is the one which is C in SSP, not this one. Because these complexes are coming in between, which is getting masked because of the fast activity. Unless you make it slow speed, then you will not pick up this slow activity. But again, show once again this picture. See that one? That complexes. That's a slow activity in SSP coming recurrently. These are all SSP complex. This is a muscle artifact. In between, this is the complex, PSSP complex. These are all SSP complexes.
This I am taking it.
These become muscle artifact. These are all muscle artifacts. So this is the MRI. This is the picture of SSP. Now, as which was telling this, age is not a bar. Even you can adult onset SSP. Is described as late as 60 years. So SSP should consider as a whenever it gets a slow myoclonus and blurring of vision, loss of vision is one of the classical presentation of SSP as well. So this is
so fast.
Pardon?
So rapidly progressing.
Yes. That is the thing you have to keep. SSP can be very rapidly progressive, and here it is not rapid. It's 4 or 5 months. It's a classical duration of SSP. Subacute and sublative pattern. And this is from the literature showing some pictures of SSP. This is again from the literature showing the occipital hyperintensity. Then there are any area of the brain can be affected in this thing. Thalamic hyperintensity is frontal lobe involvement. But most of the literature is stressing on the occipital hyperintensity. Again, other pictures. Then about adult, 1 or 2 sentences about adult onset SSP. The presenting manifestations were myoclonus, behavioral change, seizures, cognitive impairment, visual disturbances, and extrapyramidal symptoms. Myoclonus characteristically was slow and was initially featured in 64% of the patients. The interval between the measles infection and the onset of symptom longer in the adult onset group of patients. These are all from the literature, adult onset SSP clinical profile of 39 patients from a tertiary care center. These are the presentations of adult onset. That's more than 80 years. They can have myoclonus, seizures. Again, adulthood. In this study, the mean age of diagnosis approximately 21 age ranges for 18 to 43 years. Again, behavioral change, vision loss, periodic myoclonus were not that consistently present. And this another article showing about a 62-year-old woman who was rapidly with dementia and was later diagnosed having SSP. So when she initially had a little doubt only because of the age bar, but seeing the myoclonus, that is typical of SSP. Now the diagnosis can mimic like that. Any questions?
Then what treatment, sir?
Treatment, nothing can be done. I suggested amantadine, amantadine. What else can?
Inocyprosin.
I don't know if it's available here or not. Initially, we used to give. I don't know what we give at the moment. Any questions?
So here the flow myoclonus is the key, isn't it?
Slow myoclonus the key. Again, the clinical always gives trust to the clinical points. That's the guide you after diagnosis. Again, in investigation, the EEG initially was showing large, only muscle artifacts are seen. So we are not seeing any complexes. So make it slow, when the paper speed slow, then you can bend the large amplitude complex can be very well seen. In fact, I advised CSF anti-measles antibody, but the patient was not willing already. It has been done, it's not willing again.
Just one doubt.
Yeah, please.
This is not regarding this case. That earlier that young lady with muscle
Yeah.
weakness. So
Yeah.
how long did you give that steroids to have that dramatic effect?
Because CADP they improve very well. Some of them improve very well.
Steroid and mycophenolate, sir.
It's a demyelinating process, no?
So prednisolone along with MMF you have given, or prednisolone initial 4 weeks and later on?
No, MM, because she's a diabetic. So we can't wait for this to come and then again start MMF. So you want to have MMF early. MMF will take 3 months for the effect to come. So till that time, I cannot go on with the steroid. So I want the MMF to come. Anyway, I'm going to put on long-term MMF. Just it's a long duration illness.
Yes, sir.
It's not like AADP-like thing. So you have to give long duration. And we cannot maintain, anyway, she needs long-term steroid. So instead of, anyway, I'm going to change over to MMF. Then why do you want to wait? Start early simultaneously.
Okay, sir.
So then after 1 month, I can taper steroid early and late when you administer it later on.
Okay, thank you.
Yeah. So always start very beginning itself both, okay, diabetic. Yes.
Sir, in this case, the posterior lesions, can this similar lesion can occur in the PMLA and as well as the hidden hands variant of CJD?
No, CJD, the way the abnormality is a cortical ribbon sign, not hyperintensity in the subcortical white matter. So CJD can present in certain variants, you can have cortical ribboning. That can be there. But this is not the cortical ribboning what we see here.
Okay, sir.
PMLE, this is not presentation. They can have hyperintensity extending into the subcortical U fibers can be affected. The picture can very closely mimic that.
So in this patient, whether IgG index OCD was positive, sir?
IgG index, you mean to say anti-measles antibody or?
No, sir. IgG index per se and oligoclonal bands. I saw somewhere those reports.
It was positive. It is positive also that this IgG index 2.6. It is positive.
So that is also indirect evidence for SSP most likely.
Yeah, exactly. Yeah.
And OCD is also one of the criteria they have mentioned. So whether we can do, if they are not willing for CSF, we can do the serum measles antibody titer compared with the class. It satisfies the criteria for SSP.
But personally, I don't go by criteria.
Okay, sir.
The reason I'll tell you. Suppose it is not there. Still it is SSP.
Understood, sir. So we had one patient, sir, 35-year-old male, who presented with only cognitive decline, no myoclonus, no Rademacher complexes.
Yes.
So anti-measles titer came positive.
Yeah, that's the thing. You have to go back clinically only. or all images may not be positive at all. Okay, shall I go to the next one?
Wasn't she immunized for measles, sir?
That's what I said. You couldn't do the sales of anti-measles antibody, but we could have done a serum. We could have sent. Serum is not that specific. That's a problem. But as Soumya was telling, the CSF was showing oleoconal band. That's indicated that there is intrathecal synthesis of immunoglobulins.
She took the measles immunization, sir.
I no idea because I asked about it. They know everybody about whether the patient had measles at all. Nothing. They could not recollect anything.
Okay, sir.
Many of the patients SSP, they don't give the history. It might have occurred and gone. They won't remember it.
Yes, sir.
Okay. So what the last case? It's a 56-year-old man. It's a short case, but not a. It does not require you to think too much to make a diagnosis. But you must know the condition. It's a common one. A 56-year-old man with positional vertigo for the last 4 days. Now, on making him lie down flat on the cot, when I start exam, make him lie down, he developed vertigo and nystagmus. So I did not turn the head in any direction, just lying on the bed. And he's making him lying on the bed. I put it. The total nystagmus meeting to the right side in the primary position.
No. Okay.
It stopped. After some time, it stopped. Nystagmus stopped. So on lying flat, patient's horizontal nystagmus beating to the right side, and it stops after some time. So what will you do now? You take rest of the exam, it's all normal.
The lateral roll test.
Very good. It was a supine roll test. Now this is a supine roll test.
എന്നിട്ട് തല വലത്തോട്ട്
Turn the head to the right side.
ഇങ്ങനെ വെച്ചു.
You know what is happening? Look at the nystagmus now. He's lying on the right side.
Beating to the left side. ഇത് അപ്പോജിയോട്രോപിക് ടൈപ്പ് എന്ന് പറയും. Away from the ground. Beating towards the left, away from the ground. നേരെയാക്ക്. നേരെ വയ്ക്കുക.
Then made him take pain. In fact, video it was lasting for a longer period of time. Now he stopped again on making him remember the lie down flat on that coat. Now I am going to turn the head to the left side.
കണ്ണ് തുറന്നു പിടി. ഇങ്ങനെ വെച്ചാൽ
Turn to the left side.
ആ
Nystagmus beats to the
It's again
very close.
away from the ground.
And after some time it stops. In fact, I reduced cut down the video duration. That is, it just waiting a little more a longer time.
മാറി അല്ലേ? ഇത് തല നേരെ വെച്ച്
Then brought back to the primary position. No nystagmus.
വലത്തോട്ട്
Then again, for a second time, I turned to the right side. And nystagmus beating to the left.
This is more അല്ലേ?
The video taken from the head side. Okay. So what do you think? What is your diagnosis?
ഇനി തല നേരെ വെച്ചു. ഇനി അവിടെ നിൽക്കട്ടെ. ഇനി വെച്ചാൽ
Sir, which side was it more prominent?
Pardon?
On which side was it more prominent?
On turning to the left side, it is more. On turning to the, I'll show the both side once again. Turning to the right side.
away from the ground.
Turning to the right side.
Beating towards the left, away
Okay,
from
this is happening too. Now I'll show when turning to the left side.
ഇത് തല നേരെ വെച്ച്.
No, this one. This is the turning to the left side. On turning to there's more force on turning to the left side. Okay. Could you see the nystagmus? It was very
This
clear. Yeah.
Apogeotropic
Very good. This
nystagmus.
Lateral canal
Correct.
cupulolithiasis.
Correct. This is a lateral.
And on the side that is less prominent.
Correct. That is the apogeotropic type. Is of horizontal canal BPPV. That is cupulolithiasis. The next question is, which side is affected in this patient? On turning the head to the right side, patient's horizontal nystagmus beating to the left, and turning to the head to the left, the patient's horizontal nystagmus beating to the right. That is away from the side in which the head is turning, or away from the ground. That is called apogeotropic type. The question is, which side is affected here? Left or right?
The right side.
Okay, right side is affected. Correct. Now, how to detect which side is affected? Before that, why do you want to know about the side? Because that depends upon your repositioning. That decides your repositioning maneuver. Further, you must know which side is affected. So the geotropic type, the side which has got a strong nystagmus is affected side. In the apogeotropic type, the side opposite, that is side in which the stronger nystagmus is the normal side. That means here is stronger on turning the head to the left side. That means the affected ear is the right side. In the case of apogeotropic type. The case of geotropic type, beside the side has got a larger nystagmus, that is the affected side. So which was telling that is the affected area is left side. Now, this is the same thing which I said. Okay. Now, so what it's already said. Now, how do you? Another is sometimes you may not find gross asymmetry between the two sides. So it very often happens. Here it is easy. Sometimes it will be difficult. In that case, what other test you can do? You can do what is called the bow and lean test, the lying down test. The better thing will be lying down test. I'll tell you what is lying down test. That is, look for the type of nystagmus when the patient sits up as well as while lying down. Just as simple as that. So this is a bow and lean test, but just make the patient lean backward, look at the nystagmus, and bend forward and look at the nystagmus. The sitting to supine is another simple thing which we can do at the bedside. In the test, the patient is instructed to sit with the head bent, looking at their feet for 3 minutes, like this. The idea of this maneuver is to allow free-floating otolith debris to settle in the anterior horizontal canal. The subsequently, patient is asked to lie down flat on the bed and look for the nystagmus. Why do you want to do like that? Is that you move the horizontal canal from the horizontal canal from the horizontal position to the vertical position. That is the idea of why you are bringing the head from the sitting to lying down position. When the head moves from the sitting to supine, the plane of the horizontal canal changes from horizontal to the vertical. In the case of cupulolithiasis or horizontal canal BPPV, the otolith debris attached to the cupula would result in ambulopetal deflection. Ambulopetal means towards the ampulla, which results in horizontal canal to the affected side. In the case of canalithiasis, the other is opposite. When cupulolithiasis, the cupula becomes weighted because the additional weight of the cupula. So it hangs down in relation to the gravity. On the other hand, canalithiasis, movement of the particle or movement of the endolymph opposite to the direct head movement. On assuming in canalithiasis, on assuming the supine position, the free-floating particles will move away from the cupula, giving rise to an ambulofugal deflection of the suppress the fibula, resulting in nystagmus away from the affected side. So this is again the symbol from the literature. In the case of lie the patient straight backward from the sitting to supine position. Horizontal beating to the unaffected ear in the case of geotropic, between the affected ear in the case of apogeotropic. I think we'll skip that. Let us see what I've done in this patient.
ഇനി അപ്പൊ അങ്ങനെ എഴുന്നേറ്റിരിക്കണേ.
You're sitting down. Position. I did not make him lean forward. I should have made him lean forward.
Lying down.
Then made him lie down. See what is happening to the eye. It beats to the right side. This is actually what happened when I made him lie down in the first instance itself. So when I started examining him, just like it's routine, I made him lie down, then he started complaining. So he was sitting till that time. When he lie down, you found the nystagmus waiting to the right side. This again shows that patients got an apogeotropic type of nystagmus. So other simple thing is that make the patient lie down from sitting. You find the direction nystagmus. In the case of apogeotropic type, the fast component is to the side of affected ear. In the case of geotropic type, the fast component is to the opposite side of the affected ear. This others to find out which side is affected. This occurs only if you can happen to see when you lie down, see the nystagmus. Otherwise, you make the patient lean and then lie backward. You will set this type of nystagmus to find out the side. Another way is already, which is telling depending upon which side is got a stronger nystagmus. In the case of geotropic type, the side which is affected has got a stronger nystagmus. In the apogeotropic type, the side which is affected is the one with a less severe nystagmus. Here the left side is more, so the right side is affected. So our patients right apotropic nystagmus. This now look at this video of the patient. Similar. Turning to the left side. Now turning to the left side now. Nystagmus is left inside. That means it's geotropic type.
താഴോട്ട് നോക്കിക്കേ, അങ്ങോട്ട് നോക്കിക്കേ, നോക്കിക്കൊണ്ടേയിരിക്കണ്ട.
Then making straight ahead,
നോക്കി കിടക്ക്.
lying supine. Then I'm turning to the right side.
ഇനി വലത്തോട്ട് കിടക്ക്.
Right side beat again to the right side. Now at a coarser nystagmus. Be much more coarser on looking to the right side. Now turning to the right side. That means it's beating towards the ground and is more on turning the head to the right side. Means it's a geotropic type. There is canalithiasis of the right ear. Now will you treat horizontal canal BPPV?
Guffoni maneuver.
Guffoni maneuver. That is in Guffoni maneuver, patient quickly lies down on the side of the unaffected. In the case of geotropic type, only thing is side is different. That's all. The geotropic type patient on the side of the normal ear and remains in this position for 1 to 2 minutes until the evoked nystagmus subsides. The headache is then quickly rotated 45 degrees towards the floor and kept in this position for another 2 minutes, after which patient becomes receive separate position. This is for the right geotropic.
Lies to the unaffected side. That position is held for 2 minutes. Then the patient's head is turned 45 degrees toward the ground, held for another minute.
This is the right geotropic.
The patient.
Then for the apogeotropic type on the right side, what we should do in our patient should be like this. He should fall on the
Benign positional vertigo is done by laying them to the affected side,
right
in this case
side,
the right.
and then
that position is held for 2 minutes, then their head is turned 45 degree angle toward the ground, and then they may sit up.
And they can sit up. This is another method. It's called barbecue maneuver. You can rotate to the normal side. Turn to the head side by 90 seconds. 30 seconds. Keep it like that. Just like you barbecue a chicken, rotate the chicken in that grill. And turn the head like that. Rotate every 30 seconds. And then bring it to the position. Okay, that's a really short case. Any questions?
Sir, no, no question, but just a good hint for the students and the consultants to remember is that the Gufone maneuver should always be done on the side that the nystagmus is less. So if it is geotropic, you do it on the opposite side, that will be less. If you do it on the apogeotropic, you do it on the side which is less, so that will that you don't have to actually try and figure out right or left. If you just remember doing the Gufoni on the side the nystagmus is less, you will be right.
Correct, perfect. Okay, any questions?
In barbecue maneuver, do we need to keep the head end of the position at 30 degrees like this, or it should be flat?
Ideally 30 degrees.
Okay.
Because that is the position in which the canal becomes horizontal, vertical. That's why idea doing it is in the 30 degrees. Normally when you sit up, the horizontal canal is not straight horizontal. It is 30 degrees up. So make it, when you lie down, you have to bend 30 degrees so that make it vertical. You understand that?
Yes, sir.
It's not horizontal, it's 30 degrees down. That's the reason why. Okay, shall we stop here? In fact, I had prepared this, how the mechanism of producing this, apogeotropic and geotropic type of nystagmus horizontal canal. I think in the interest of time, I'll skip all these things. So any other questions in this case? Okay. Shall we stop? Hello?
Yes, sir.
Yes.
Okay. Now before we close, in the last class, people are asking whether we can change the timing for the session, because on many Sundays, many conferences are happening. So people want to go for the conference. For example, next Sunday again, we have to cancel our meeting because next Sunday is a sign program. Last week, we had to cancel IANCon meeting was example. Many conferences are likely to come. And almost all the conferences are likely to come, be linked to either Saturday, Sunday, or it will be aligned around the Sundays only. So I was talking to Sudhir Kothari, who was the organizer for this meeting. He said we can change to any day at our convenience, depending upon your suggestions, except in Wednesday. Wednesday is another sci-fi program. So apart from that day, we can you can choose any other day. If you want at night, we can do it at night, because the daytime you have to go to the hospital. So I want your suggestions here in this context. Which day is convenient for you all? Then we can fix it on that day. I am convenient for every day except Saturdays.
Weekdays at night would be perfect. I mean,
yeah, you tell me which your convenient time. You tell which day you can tell. Is it Friday, Thursday? I mean Wednesday. Fine, people they are not agreeing for that. Wednesday they got some other time.
Friday on Mondays nobody will have
7 to 8:30, sir. Friday, in case if there are many meetings, then we can do on the previous Friday 7 to 8:30. I mean, that's my opinion.
So we can make it 8 o'clock, no? Because
yeah.
You mean many people OPD we are only by 7 o'clock or so.
Okay. 8 to 9:30. That'll be fine.
Monday or Tuesday, there may not be that many programs. Friday again, week.
Yeah.
Then we can make, okay, we can make it Tuesday. What about others? Anyone have an objection on Tuesday or Monday? Can tell. Which is it okay for you on Tuesday?
I think most of the Mondays that nobody will be doing anything, but Tuesday is also fine, whatever other people are comfortable with.
Okay. What about others?
Basically, what are you comfortable with, sir?
No, I have got no problem. Which any day I'm coming. Any day. I am only interested to doing this kind of.
We are comfortable anytime. You can tell.
No. I think it's here for time is more important, no?
8:30, sir. 8:30. 8:30.
Okay, we can meet. Yeah, whatever you say, I am agreeable.
Tuesday,
Okay.
8:30.
Okay, what do
I
you
think
yeah, tell me, you are with the senior most, you can tell. Suggest.
no, well, I don't work really very late, but most of the younger colleagues would be working. So 8:30 would suit most of them.
Yeah.
I don't work in the evening, so I'm okay with any time. But 8:30 for most people would be good.
Okay.
Now the question is only Monday or Tuesday. Let them say what is
Okay.
the Monday.
So time. Yeah.
Monday will be very busy,
They
sir.
won't-
Monday most people will have very
busy,
empty.
busy.
Yeah. So Tuesday would be fine. So maybe
Yeah.
8
to 9:30 would be ideal, I think, because if it goes beyond 10 o'clock,
Yes,
I
sir.
mean,
Yeah,
8 to
correct.
9:30 would be fine.
They will make it Tuesday 8 to 9:30. Okay.
Yeah.
Yes,
Okay, sir.
Yeah, I'm good with that. Yeah.
Yeah.
Okay, which is okay with you, Butch?
So
Yes,
yes,
I'm absolutely.
Okay.
Tuesday,
So
8:30. 8:30.
we'll make it Tuesday 8 o'clock, no? It is 8,
Yeah.
9. If
I think most of the colleagues who are working would find it difficult to reach back home by 8. Those who are new in practice, 8:30 to 10 should be fine.
Okay, we'll make it.
And we'll see. Yeah, and we will make sure that we don't extend it too much, because this is a weekly meeting, so we have all the time in the world to complete whatever we have to do.
Okay.
Sir, this is only on those days when there are meetings, right?
8:30 people are practicing, no?
No, sir. My question is, this change is only for those Sundays when we get meeting.
No. We fix it every day, every week. So
Every week. Okay.
All right.
Okay. All right.
Will difficult.
So
Okay,
Tuesday 8:30.
Tuesday
Okay, sir.
8 to 10 every Tuesday. Okay.
Yes, sir. Okay, sir. Okay.
So next Sunday there won't
Yes,
be.
sir.
Yeah. Next Tuesday will be next meeting will be on next Tuesday, not on Sunday.
Okay, sir.
Yeah. Okay, sir.
Okay,
So
sir.
I mean, after
Okay.
3 days.
Thank you.
Yeah. Pardon?
Today is Sunday, no? So Monday, Tuesday. So will there be any meeting this Tuesday?
Not this Tuesday.
Next Tuesday.
Next.
Okay. Okay, fine. Okay, fine.
Tickets to find people and other people, no?
Yeah, okay, fine.
They have to take them accordingly. So from next Tuesday onwards.
Okay,
That is from, for example, 3, 4, 6 or 7.
Okay, sir. Right.
I put it in the chat.
Yeah. Thank you all. Thank you.
Thank you, sir.
Thank you, sir.
Thank you very much.
Thank you, sir. Thank you. Good day.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, Butch. Thank you.